Definitely, we've known for a long time that certain features in chronic lymphocytic leukemia are higher risk from the time of diagnosis. So for example, IgHV unmutated CLL is generally more aggressive biology than mutated CLL, and this persists in the relapse setting as well. P53 aberrancy, so deletion of the P53 gene or mutation in the P53 gene, and in the relapse setting, actually 2/3 of patients have both of those if they do have a TP53 aberrancy, is also a high-risk feature. But we're learning more and more about resistance to targeted therapies. So with the BTK inhibitors, both covalent and non-covalent, really we've found multiple resistance mutations in the field that confer resistance to both covalent and non-covalent inhibitors. I don't think it's quite ready for prime time to change therapeutic decision making. I do think it highlights really the critical importance of BTK and B-cell receptor signaling in CLL. And so ways to overcome that can be alternative agents, so BTK degraders, the bispecific antibodies are emerging therapies. The other ways are that most of these newer drugs start in clinical trials. They start as monotherapies in heavily pretreated patient populations, moving them up into earlier lines of therapy once we have more safety and efficacy data. Combination therapies, so combining with other mechanisms of action. And then another way to really try to attack resistance is to do fixed duration treatments, get patients into a deep remission, and then have time off therapy. So there's no one biomarker right now, but definitely we're learning more and more about resistance and ways to overcome that.